So as Terry said, today's panel will be about mental and behavioral health impacts of disasters. And just as you could tell from each of these panelists' backgrounds, we have kind of a wide variety of experience. So I think what we'll do is we'll allow each of the panelists to come up and give kind of a brief sort of introduction and presentation on their experience in this field. So if we could start with Troy.
Hi, good afternoon. I just wanted to add a little bit of information to all those other titles you already heard. In addition to the service that I do for the Department of Health in the state as the Disaster Behavioral Health Coordinator, in my role, I also provide crisis intervention training for the staff of the outpatient mental health clinics and clubhouses across the state. And I've been doing that for about 20 years. I did it previously at my former employer, Queens Medical Center, when I worked there as a psychiatric assistant and a social work assistant in the Locke Psychiatric Unit. So it's been really helpful in informing my practices in being a partner in behavioral health disaster preparedness. What I wanted to just go over with you folks, today is what the role and responsibilities of myself, the Adult Mental Health Division, is pre-disaster and post-disaster. And I've kind of outlined it as follows. In the event that there is time to prepare prior to a disaster, we're working on getting as many staff as possible in the Behavioral Health Administration of the state versed in crisis counseling and psychological first aid. We also, as a part of our ongoing preparedness efforts, review our emergency plans and revise them accordingly. And as time allows, we collaborate with the SAMHSA Center for Mental Health Services and the Disaster Technical Assistance Center, which provides technical training and support for all states and counties across the United States and the territories. Post-disaster recovery, after a disaster, this is just in the context of a local disaster declaration. Our neighbor island staff in the Adult Mental Health Division, at least, takes direction from their respective district health officer. On Oahu, where I'm the branch supervisor for the outpatient clinics and and the clubhouses, I'm third in line after my supervisor, Dr. Mark Freitas, the administrator of Mental Health Division. And I think Dr. Jim Westfall, the psychiatry chief for the Adult Mental Health Division in the Incident Command Center. So I assist as needed and also assist as needed in the collaboration with the American Red Cross, the Medical Reserve Corps, and public health nursing. So similarly, in a disaster that ends up being declared a presidentially declared disaster, we do the same thing pre-disaster, but then what's different post-disaster is the department would need to decide if we want to apply for a crisis counseling assistance and training program grant. And if we do decide to do that, we'd work with the SAMHSA CMHS folks to complete the grant application and do what is necessary after we get the grant approved. So I won't go into the details right now about what a crisis counseling assistance and training program is. I'll kind of leave time for my partners here to go through their material. But if people have questions more about what crisis counseling assistance and training program is in detail later, you can ask me. But in general, it's a program that includes psychological first aid concepts. It's something that's provided for people post-disaster to help them cope with their responses to trauma, to stress. And it's provided in a non-treatment methodology. So it's supportive, it's to build resilience, it's to help people identify their resources, and it's something where we don't keep any clinical records. We're not doing any true clinical treatment. It's helping people identify what their strengths are and what resilience they have to access their support network. So I'm just gonna leave it at that, and then if you have questions later, and my friend Bruce here, I think it's just really important for me to always remind myself that I have a lot of, maybe in my view of the world, a lot of knowledge about what to do as I've gone to training at the National Emergency Training Center, FEMA in Emmitsburg, Maryland, but I've not really had the opportunity, I guess fortunately, in a sense, to apply it. And having the will to do something is important, but I also got to do it. So I look forward to any of your questions. Thank you.
Thank you so much for that. If we could have Representative Ryan come up and speak.
Aloha. All right, got some life still in you after lunch. I was so happy to be asked to talk today because it wasn't on rail. So since it wasn't on rail, I said, sure, I'll talk about it. What did you want me to talk about? And if you look at the description, just to let you know, I am really legitimately volunteers with all of those groups. I've been a volunteer with Merck for a few years. See some people nodding. We've been in pod trainings. I'm active with Red Cross. That's who I thought texted me. And then I also I'm a trainer with this youth mental health first aid program. And they actually all work together. And so I was really glad to be here to explain to you what the program is about and just give you some insights on why it's actually available and valuable for any community. So basically, Youth Mental Health First Aid Program, it was a program that is sponsored by, was approved by SAMHSA. It's basically an 8-hour program designed to teach the average person about what to do in a mental health situation. Okay, it doesn't train you to diagnose. It basically trains. Is that better? Too loud. Hey, you're supposed to make me look good. Come on. Lower tone. No. Okay. And so, but what it does is it's an 8-hour training program in which it takes trainers like myself who went through the program and get certified, and we provide it to a wide range of participants. So just for example, recently we did training to health professionals at a health center, and previously before that we did training with community people out in Kalihi. And basically what it does is it uses the same kind of concept of how we teach the average person to do CPR, where it's just, compressions, breath compressions, keeping them until they get to the right professionals. Youth Mental Health First Aid is a program in which it gives the average person some basic knowledge, some basic confidence, so that way when they encounter certain issues, that they can get past any stigmas, past any type of myths and misunderstandings about what mental health is, to help that person get to the right place. So it's a 5-step program. It's labeled after ALGE, and ALGE stands for, I don't want to make sure I screw it up, right? It's ALGE. A stands for assess for risks of suicide or harm. L stands for listen non-judgmentally. G stands for give reassurance and information. E stands for encourage appropriate professional help. And the final E is encourage self-help and other support systems. So the reason why I got involved with this program is that it actually started off in Australia. It was brought to the attention nationally and sponsored. And right now in Hawaii, the great opportunity is through the Department of Education, they're providing this training free of charge. They received a grant. I think they have another 1.5 years on the grant, in which you work through the Department of Education. They'll come out to any community group to provide this training free of charge, which includes the manuals, and the training material. Normally, if this was provided outside the DOE system, you would actually have to pay for the manuals. So it's a really great opportunity to help share make people, the average person, aware of not only suicide and harm, but just mental health issues in general. So we touch on things like bipolar, depression, we talk about psychosis, but we don't go into the specifics. We're not teaching people to be therapists. We're not having them do diagnosis. All we want them to know is to be aware of some of the visible signs or non-visible signs and help that person get to where they need to. So it's a really great program, a lot of great feedback, and where people were actually, the feedback we received is that, they've seen this, they feel this way, but they never have to actually go through a program that taught them what to say or what to look for, right? And so, we've actually had, we actually have people who are professionals provide feedback, saying that this is great, and some of them moved on to become trainers themselves. And again, it's about an 8-hour program, and then once you complete the program and you pass a test, you get certified for being a participant for 3 years. So we've been sharing this not only with medical facilities, but also community groups. And we have trainers on every island, and if you are interested, we can give you the right contacts, or if you interested in taking the program or becoming a trainer yourself, you can go to Mental Health First Aid and put in your zip code, and it'll pull up trainers. Okay. And one final thing, since I'm up here and I've been involved with many of the volunteers as a volunteer myself. Many times when we're out there, we forget to take care of ourselves. Right, we're so worried about our patients. We're so worried about our community. We're so worried about, filling out the right forms in the timely manner and all that. And so one of the things that this program is great is that there is a focus on making sure that since we're one of the people on the line providing the service, that we also make sure that we are okay at various times. And so if you have any more questions on that, I'm happy to answer them. Thank you.
Thank you so much for that. If we could have Jeanelle.
Thank you again for the invitation to speak on this panel. I think we all uniquely, as our moderator said, have different aspects or work in different disciplines, but yet there's so much overlap. And I think, just again, thank you for including mental and behavioral health in this conference. It's just so important. So one of the things that I wanted to touch on today is just some of those concepts and why, even though we're talking mostly about disaster management, crisis management, et cetera, again, to think about the mental health aspects. But also, I do also want to talk about self-care, like Rep. Yamane just talked about. And my area is suicide prevention, so every training or presentation that I do, I talk about self-care, and that's the first time that the audience rolls their eyes at me. Like, oh yeah, self-care, yeah, sure. But really that there's so much research and there's so much attention now to say, please take care of yourself as first responders. And those that, you see it every day, you deal with the stressors every day, but really that to make sure that that's an important part of your just profession, that you do that. I do want to say I'm a public health professional. I'm a preventionist. So I'm like you, try to hang on the left side of this picture to do primary prevention. But admittedly, the majority of my job dealing with suicide and suicide prevention has been towards the right side. Most of my work has been with crisis and emergency departments and working with those who are already struggling. But we are trying our best to get to the left side in terms of primary prevention and make sure that we're doing our best to move upstream as best as possible. So I'm going to speed through some of these just kind of general diagrams that I have. Sorry, yes, I'm the academic on the panel too, so I have diagrams for you. So a couple of things that I pulled out of some of our suicide prevention trainings that I thought cut across different mental health and behavioral health issues in terms of crisis and disaster. I like to start every talk by talking about the why. Why are we even talking about this? So in terms of mental health and disaster, we know that you guys know that the first 72 hours, the 2 to 3 days after disaster, it's just chaos, right? And a lot of people are making decisions based on emotion. There's what they say, emotional turmoil. And so again, want to remind yourself, as we go through these processes, please be gentle to yourself. People process in different ways. And in my field, we have a saying, good postvention is good prevention. Because if we deal with disasters, if we deal with suicide deaths, et cetera, if we deal with mental health crises well after they occur, they actually, research is showing, can be very preventative for the next time if other things occur. There's a couple of concepts that I want to just make sure that we're all familiar with. So of course, trauma, of course, that's kind of a cutting across concept that we're all talking about, that there's different types of trauma. So there's a couple considerations that I want to put out for those of you that are first responders or working in emergency services, that the crisis response itself and the intervention itself can intensify trauma, correct? Many of you that are on the front lines know that somebody who has just experienced a disaster, whether it be natural or man-made, the response itself, if it is not handled appropriately, can actually intensify the trauma that they are experiencing from that event. We know from our research locally, including research on events like Hurricane Inouye, that symptoms can be immediate, but they can also be delayed. And we actually saw delayed symptoms or delayed trauma responses in populations like teens and young adults, as opposed to older people and young children showed symptoms right away, but we know that it can actually be delayed. Individuals can be affected even secondarily, correct? Even though they're not at the scene or they're not directly impacted, just knowing somebody or seeing the media, et cetera, can impact them. And generally, and I found different statistics, about 20 to 50% of the general population have past forms of trauma, whether that be through a natural disaster or personal trauma or abuse, etc. So again, if they're coming already with a history of trauma and then they're experiencing another crisis or disaster, and on top of that, the response that they're getting from emergency management is not handled in the most sensitive manner, then we're just combining all of those things together. So like I just said, the effects are cumulative, and we see that from research. Especially if they're experiencing chronic stressors, chronic trauma over and over again, it does appear additive. And so we have to consider those things in terms of our response. And unfortunately, and I'm preaching to the choir, many of people who need specialized services don't seek them or aren't receiving them for different reasons. I do want to also talk about coping. Yes, there's different strategies. It's very individualized. Even a small stressor or not so big of a disaster, so to speak, can trigger something for an individual. But also, on the other hand, we do try to talk about resilience, as Troy said. So there's many people out there who are experiencing daily chronic stress and trauma, and yet they do not require mental health services. They have some kind of resilience factor. And of course, we know, again, these are very individualized responses. Things like coping, things like grief, which I always also wanted to bring up, since that is a daily part of my profession, is dealing with those who have lost loved ones to suicide. That grief occurs and processes in different ways. It's very personal, it's very individual. So I know that, again, we're talking more on the public health or population perspective, but please know that, of course, all of us do process, grieve, and cope in different ways. Burnout, our favorite terminology to think about when we're talking about first responders and crisis management. I also wanted to talk about briefly compassion fatigue. I don't know how many of you have heard this terminology before. Okay, most of you, that's good. Sometimes I do trainings and this is a brand new concept for people, but that there is now much more support compared to maybe 10 years ago in terms of supporting first responders and it's those that are in law enforcement, et cetera, to help support those of you that are helping professions, but that there is fatigue over time as you see crisis, as you see people in bad situations, there can be compassion fatigue. So I just wanted to one of my biggest things I like to push in terms of response to is policy and protocol. I don't need to preach to the choir to you guys in terms of why it's important. We want to standardize, we want to formalize, fill in the pukas, and if you have a protocol, great for response. Even if you can't apply it, as Troy just said, walk through it. And there's many times that I've gone through with the organization to their crisis response protocol, and we have found pukas. So find them now before you actually have to implement them and use them in crisis times. A couple of reminders, and I won't go through these in detail, of what should go into a good protocol. Not just procedure, but also helpful tips on how to engage with the community. What are some helpful or not so helpful things to say? And please don't forget prevention belongs in your protocol too. So what are those preventative measures you're going to do to make sure we're thinking about crisis management now during time of non-crisis? And also debriefing is something very commonly I find missing from protocols. After crisis is managed, after things die down or quiet down, what is the debrief process going to look like for those of you that are actually responding? And please consider everybody touched by the incident, correct? Not just those directly impacted, their networks, witnesses to whatever the event was, yourselves, response workers, etc. I have the picture here of the SAMHSA disaster kit, which many of you are familiar with. It's a very good toolkit and one that's freely available from SAMHSA to use. We actually pass these out to the HELCO workers on Hawaii Island after all of the big natural disaster, et cetera, to the guys on the front lines trying to do all of the road maintenance and repairs, et cetera. So it has a lot of uses. And then I wanted to just end today talking specifically about suicide prevention. I know it's not a suicide prevention training, but it's just some best practices, because when you think about disaster and crisis, it's such a broad definition. But I do want to say, yes, responding to suicide death or suicide deaths in clusters, for example, is something that could possibly run the gamut of what you guys are dealing with. So definitely we want to, again, obviously provide that support to family and friends, help shape the community's desire to do something. In response to many natural disasters, et cetera, the community nicely tries to get together and collaborate and do something about what just happened. And there's just some special or significant things that we do in the case of suicide deaths to kind of hone and shape that so that the response is appropriate and it's not going to cause more contagion of those suicides. These are briefly the safe messaging guidelines. You can read through those, but we do have these guidelines specifically when we're talking about mental health or suicide crisis, especially death response. So there are some guidelines out there. You can let me know if you have questions on handling post-suicide issues. And then finally, just again, encouraging actions, community connectedness, addressing myths and misinformation, and of course, promoting resources. So I'm going to end by talking about briefly some resources. Our crisis line of Hawaii, yay, Dr. Freitas, thank you. We work very closely with Steve Balcom there, who runs the crisis line, and also our 1-800 number, 1-800-273-TALK. Memorize it. If you don't remember anything else I said, memorize that number. And here's the other resources that are commonly given. There's also a crisis text line now, if you weren't aware of that. If you text 741-741, you get a text response. There's also a lot of resources on Facebook. If you see somebody post something on social media that might be, making you feel not so good about, well, maybe they're in a crisis or they're not in a good place, there's ways to actually refer those posts to crisis resources. And then finally, this is my PSA for our local task force, our AFSP chapter, as well as Mental Health America of Hawaii. We also partner with folks like Department of Education and our youth mental health first aid trainers. So we're a big network, but there's of course a lot to do in terms of response and prevention. And then, yes, I will end on self-care. Please, 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 self-care, it's hard work. Thank you for doing what you do. No joke, make a self-care kit, whatever that means to you. And I put an icon down here for the virtual Hope Box. It is a free app that you can download, and you can make yourself a virtual self-care kit. So just put pictures or video games or anything else that helps you to just de-stress. And so that can be something that is very portable that you could even take with you, and just prioritize at least a few minutes a day to decompress, de-stress, especially with the types of professions that you all come with. Okay, thank you very much.
Thank you so much for that. Lastly, if we could have Jerry come up.
Good afternoon. Unlike the rest of the panel, I'm the only member of the panel who's not a mental health expert. So like police officers are prone to do, I'm going to begin with a story. Back in the 1980s, when I was a rookie, brand new in the department, my hair was still black, and I was driving around one of those scooters downtown in patrol. I responded to a call of a suicide in progress, a possible suicide in progress at the First Hawaiian Building on King and Bishop. So when I got there, my sergeant got there too. There was a man standing on a ledge about 15 stories up in the building. And unfortunately, he was standing above the only entrance to the building. So we wanted to enter the building and go up and talk to him, and of course try to negotiate with him to come off the ledge. But it was difficult because in order to get into the building, we would have to walk under where he was standing. So we waited there for a while, and right when the sergeant told me, let's go in the building and have a talk with him, we started approaching the building, and sadly, the man jumped. So I had to watch him fall from 15 stories up in the building and land maybe 30 feet from where I was standing. So instantly, as most police officers do, we jump into this like an automatic mode. We start methodically doing our job, preserve the crime scene while EMS is tending to him, and I set up a perimeter. And I found that my supervisors and other policemen will pass by me and say, hey, I think you better take a break. I think you better go talk to somebody. And I was wondering, why do they keep telling me that? So officer after officer told me, you better go see the psychologist. So finally I asked somebody, why are you telling me that I have to see the psychologist? And they said, because your face is completely white. So police officers have this tendency to resist getting help. They see themselves as the helpers, as the responders, as the ones who are providing other people with help. And sometimes it's difficult to get them to realize that it's natural and it's okay for them to get help. So one of the things the department did in the 80s was they founded what we call the peer support program. It was founded by Major Gerald Brown, who's now, my understanding, is a psychologist. It operated somewhat informally up until about the 1990s, and then Sergeant George Smith took over as the first full-time peer support coordinator. The program is made up of fellow police employees, and what we find is that when police officers need help getting through a traumatic experience, they're more likely to speak freely in front of another police officer because they see other police officers understanding what they go through. So the mission of the peer support program is to provide emotional support, service, and assistance to both police officers and their families. And the method they do that is through debriefing and diffusing techniques, where they'll have a debriefing after a traumatic event and talk to those involved. And sometimes, yes, it does lead to the officers talking to the psychologist, but they start off by talking to a peer, someone who they think understands what they're going through. So there are some important elements to this program. First of all, the participation is voluntary. We haven't found that it helps to mandate officers to go to such a program. There are some other critical elements such as autonomy and confidentiality. The program operates independently of the police administration. Administratively, yes, the department has oversight over it, but if officers feel like the chief and the deputy chief and the assistant chiefs are running the program, they're not going to feel as comfortable speaking before their peers about what happened at the scene. So police administrators like chiefs and majors and captains, unless they're involved in that event itself, they don't attend the meeting. It's only the people who are involved and the counselors. And of course, confidentiality, as I mentioned, is important because we don't want officers to think that something they say in the meeting or in the debriefing is going to come on and result in disciplinary action later on. So unless what they discuss amounts to expressing a desire to hurt themselves or hurt someone else or commit some kind of criminal act, then whatever is said in the debriefing is completely confidential. So the peer support program is that receives training from the International Critical Incident Stress Foundation, and they receive overall guidance from that organization. And we found over the years that it's helpful to allow police officers, and I'm sure other first responders as well experience the same thing, that they're willing to speak about how they felt because they're talking to their peers. And obviously, if the trauma does result in adverse effects at work, then at that point, the department may mandate psychological intervention. But we start off with the peer support program, and we find that it's helpful to getting our officers to cope. Thanks.
Thank you so much, to all of our panelists. I think this particular subject really resonates with me, and I think no matter where you come from as far as your organization or what job you have, I think we can all sort of understand the need to have sort of like self-care tips for psychological first aid and really taking care of not only our communities but ourselves as well. So thank you so much for all of that information. So now we'll kind of start off with a Q&A, but I will go first to get you guys primed and ready to ask all of your questions you have. Kind of like I mentioned before, I think no matter where you come from, first responder, healthcare or not, this idea of mental behavioral health impacts during a crisis affects us all. And so I was wondering, and I know, Jeanelle, you kind of touched on it as far as like self-care, but from each of the different panelists' perspectives, what do you think are some practical tips that we as the general population can use to kind of take care of ourselves during or after a crisis?
Tips, okay. I think the best tip is take some initiative to recognize that you're not perfect and that you have opportunities to strengthen yourself in ways that can make you better for not just yourself but for others. So I feel, for me at least, one of the, kind of like I guess the big book or the 12 steps, you gotta kind of admit you have an opportunity to be better, that you're not perfect, and ask someone, I guess, that you trust and that you feel might be a good resource for information, what you're comfortable asking for, what resources there are out there to strengthen yourself emotionally and build your resilience and decrease your vulnerability. And if you don't want to do that, you can go online to SAMHSA, CMHSC, Center for Mental Health Services Administration, and get a lot of resources there. But I think the first step is really the hardest, and that is to just recognize that you can be better, in a better place emotionally, and make yourself more competent and confident to deal with any adversity, but it really takes some insight.
So essentially, just being okay with knowing that it's okay to not be okay.
Yeah,
Okay.
exactly. And part of the crisis counseling program efforts include dialogue, having a dialogue with people, engaging with people, and as they're willing to talk about their experiences, help them feel like it's very normal to feel grief, to feel stuck, and that maybe they will accept that and just get past that point, or maybe seek help. But I think we deal with this every day in mental health, or a lot of times the stigmatization and recognizing that maybe you could do a better job of taking care of yourself. And sometimes you don't recognize it until it's manifested in a way that you're getting physically sick, right? So I just think that the first tip is self-awareness.
That's great. Thank you.
Let me chime in. I have to answer this well because part of my volunteer work at the American Red Cross is I'm a disaster mental health worker. So that's part of our role, right? So, and actually I've had the pleasure, the opportunity to deploy nationally on 2 occasions, as well as deal with incidents in Hawaii, including things like shootings and very traumatic events. And, you know, so my feedback on that is, besides what was presented, is that, you know, we all work in a field in which we have colleagues, friends, and family that look out for us. And one of the difficult things that we have is when we're in the midst of responding to a trauma or processing it, we get hyper-focused on our tasks. And many times when we get hyper-focused on our tasks, we easily give up making sure that we are okay. And then that becomes a problem because it adds on to that. And then when we do start to take care of ourselves, we feel guilty. So many times in disaster response, I have to monitor my colleagues because they tend to skip eating their meals, right? They forget to take breaks because they feel guilty that if I eat and these people need food or they need cleaning materials or disaster kits, that, you know, every time I relax and take care of myself, somebody else doesn't have that. And so one of the things that we focus on in as disaster mental health is to remind the person that in order for us to give, we actually make sure that our cups are filled too. And that includes things like watching out for each other, having people look out, like the chief said, where others notice something different and then recommended take breaks. One of the things is one time I was on a deployment, I needed to ask one of the frontline caseworkers to take a break. She refused. She didn't want to take a break. So I asked her supervisor to relieve her for an hour. And when she came to me to argue why I relieved her, I said, you know, just go out, take a break, but look at the sun, get some fresh air. She came back, started crying, and said that she didn't know she needed that until she was actually forced to sit there and not think anything else except herself. And so, a lot of these things we can do for ourselves, but many times we don't pull the trigger to do it because we're so focused on helping others. And so I think part of that toolkit you got to have is making sure your team is also looking out for you.
I guess, again, just the help seeking, I feel like I'm a broken record every day of my career. That's my job, is to promote help seeking. And help, having choice of help, like what Jerry was talking about in terms of choosing to talk to a peer as opposed to going right away to that psychologist. We promote whatever help that means to you, whether it's going to your chaplain or going to a peer, going to a physician, going to a friend, going to a family member, but help seek. And I think we are the most guilty at not modeling help seeking, even though we're trying to promote that help seeking. And taking breaks, whether it's breaks during crisis response or just a break for a while. Especially in suicide, I had a colleague who experienced a personal loss of a close family member, and she called me right away, and they had known that person had been struggling for quite a while, and unfortunately, they did take their life. It happened in another state, so she had to go and take care of the family there. And she said, please don't schedule me for any events or trainings for a couple of months. And that was just her space, identifying that she needed space, that she couldn't, in her best interest, talk about suicide prevention while grieving for somebody's suicide that was very close to her. So just model it as best as we can. I know that that's difficult to do in a lot of our professions, but taking that time out and just like Troy was saying, that realization that, whoa, that's me. Like I fit those criteria as we're training it. It's like I fit 9 out of 10 of those. Oh my gosh. So I think maybe it's time that I take a step back to evaluate my readiness to be here at whatever response or training or event that I'm doing.
So as everyone mentioned, it's important to be able to get help. And I think in the police department, there's a subculture. There's a subculture that the officers have that's separate completely from the administration and the supervisors and the commanders. The subculture can be good and bad. The subculture teaches them to take care of each other, take care of your own workload, do your work like you're supposed to. But the subculture used to, anyway, tell them that it's not okay to seek professional help or to have these symptoms of, of problems after experiencing a traumatic experience. That subculture used to tell them, you're a police officer, you just take it, that's your job. Fortunately, with the advent of the peer support program, we find that the subculture in that respect is gradually changing, where it is okay, especially since some of your peers are the ones that are going to be counseling you. People are starting to realize it's okay. It doesn't mean you're not normal. It doesn't mean you're not a good police officer. It just means you're a normal person, a normal police officer who went through an abnormal experience, and now you can get help for it.
I just remembered, we have an integrated care model that we're practicing at a couple of our clinics, and part of that program includes showing videos to our clients in our waiting rooms. And one of the videos that the clients chose to show in our waiting rooms was a video of The Rock, very masculine man. What's his name? Johnson? Yeah, him. Dwayne.
Not that I know or
Okay.
anything.
And it's a short video, but he describes how he went through a period of depression. And for some people, maybe in some subcultures where admitting that you need some help is a sign of weakness, maybe maybe having somebody to associate with that's like you admit that it's okay, it can make a big difference, and people can start getting the help they need to be stronger.
Thank you so much for that. I was talking to a young lady during lunch, and we were just talking about, and all of this resonates so much with me, is I did a deployment for Ebola, and I came back from Sierra Leone, and I just felt like, you know, people are complaining about how their Starbucks is not hot enough, and it's like, what planet are you on? Because I'm like, I can't identify with you. And so being able to surround myself with people that had been through that, I felt so much comfort. And then not just from like a professional experience, and I think all of you in this room can identify from a personal experience, you know, when you're going through grief, I think something that I've learned recently is that knowing that it's okay not to be okay, and to ask, you know, your job or your boss, please don't give me anything, you know, that would cause me to have to relive that, or, hey, I need to take some time off of work, and feel okay about not feeling guilty and doing that sort of self-care for yourself. So thank you so much. I just found this panel really, really great. I want to open it up for anybody else that may have questions. We have a young lady in the front.
Well, I didn't want to disappoint the representative, but I do want to ask why the rail's not coming to the North Shore. No, I'm sorry. Forget the politics. Wait, did I wake you up? So having a mental health background myself as a clinical therapist, et cetera, I wanted to capitalize and see if we can make it pervasive, because we all know grants end, as you mentioned. And having done tobacco control and the 5 A's and how we spread that training, how we could train more people before this grant ends and get more the trainers, because living in one of the rural communities on Oahu, which is North Shore, Waianae, and Waimanalo, we do not have enough behavioral health professionals at any level. And if we could get more people trained in this 8-hour training, no matter what, like you said, what level they are, if they're advanced, whatever, like the outreach workers, people working with homeless, I really think we need to capitalize on this now before the grant ends, because this is an awesome thing, and I didn't know about it. Because, yeah, we really just don't have enough behavioral health professionals in the rural areas especially. And everybody knows about the homeless issue. So thank you, Representative.
Thank you.
Can I add on to that? Sorry. I'm going to capitalize on your comment. In conjunction with Youth Mental Health First Aid, hey Gordon, don't think I don't see you back there. He's Director of Project High Aware, if you don't know. One of the things that I do within the task force is to coordinate the suicide prevention training network across the state. So the Department of Health's EMS branch receives a not terribly large pot of money to do suicide prevention trainings across the state, which make them freely available as well. Some of you may have attended those trainings, Safe Talk trainings, Assist training, Connect, one of those. So now we're strengthening our partnerships to then now offer Youth Mental Health First Aid. Mental Health America offers youth suicide and bullying prevention training, Grow a Rainbow training, which is for LGBT issues. So we can somehow get information or resources to you to we put together what we call a training menu, and the majority of those trainings through grants or other state funding for the moment until things cut or go on their way are free. So we're able to offer trainings, and also if your organization would like a trainer to come into your organization, we're able to arrange that as well right now with the funding that we get. So just wanted to do a little PSA for that.
Do we have any other questions from the audience? I think we have one.
Thank you. I'm enjoying the whole conference and particularly this panel. And I'm an old public health nurse, and I teach at UH in public health. But one of my jobs in between was I worked for Hospice Hawaii. And one of the things I haven't heard these 2 days, and I'm sort of setting up future conferences, is our fear of death and dying. And what Mark pointed out this morning is how many deaths happen almost immediately in a disaster. And then we had two wonderful on this panel about suicide, which is a traumatic death that we're not expecting, that somebody is mentally having concern. And it seems to me that all the people in this room who have been here these 2 days, I know some have left, is we're sort of the front and maybe second line defense in any disaster. I'm a volunteer for the Medical Reserve Corps also, and there's lots of public health nurses here and civil service, and we're all working together, and we don't have these bigger conversations about it's no fun to see somebody die. You know, I was an emergency room nurse, young, and saw my first death in an emergency room of a young boy. I was in a pediatrics. I'll never forget that, just like what Troy shared with his suicide witness. And so where are we going to go with this? Why aren't we bringing in more people to talk about we're all born and then we all die? And some of them are traumatic deaths, and it's terrible, but we need to process that in a different way. And I think it has something to do with emotional well-being. Any reaction to that?
I'm not a subject matter expert like these guys, but I would say just from going through my own personal experiences with death, it feels like we as Americans don't deal well with death. We don't know how to talk about it. We don't know how to approach people that are grieving. Sometimes it feels like, you know, I'm like a leper or something. So that's just kind of my 2 cents. I don't know if you guys could kind of agree, disagree?
Can I touch on that since I worked with public health nurses and Dr. Char, who left, knows that I used to work in Queens ER as a medical social worker for many years, amongst many other jobs like care coordinator, DOH, and other. But in regards to death and dying, I noticed when I was working in the ER, it's a very difficult conversation to have. And just like with this program with the youth mental health, it's a very difficult subject to breach, even when people are healthy. When you talk about families talking about how to do, what do we do with, medical orders if somebody becomes unable to be responsive? Many families, many people here probably haven't had that full discussion with their loved ones, their parents and their children about what to do if something traumatic happens until they're actually faced with it. And in my experience, working in the hospital and out in the community, is that sometimes the medical professionals that know the best are the most difficult to work with. Ever tried to have them fill out the forms? They can ask another patient to fill out the 20-page form, but you get them to fill it out? I mean, it's very difficult. So I think what happens is it's a discussion that we have to make people feel comfortable with. So when I teach or teach at HPU and Phoenix, and before I taught at ACC, part of the discussion that we have with my students is the fact is being healthcare providers means we have to touch on things that are uncomfortable. And we actually have to role model that and push that and get other people to talk about it. Not just telling our patients at the point of entry, this is what you need to do because, your loved one now has 6 months and we're doing hospice. One experience I had, I was working at the hospital. We had a young man who was younger than me, had brain tumor, and he was going to pass away in 3 months, and his daughter was 11 years old. During that whole time, he had no discussion with his wife or kids about it. Once he left, I went in there, and he was having depression, so I had to sit down with him for an hour because he felt so bad. He didn't want to talk to anybody in his family because he didn't want the last impression of his daughter and the family to be sad, right? And so we came up with a whole care plan for that. But that discussion, that's the frustrating part, is he was a healthcare professional. And so, for me, one of the things is I think part of the solution, just a piece, is educating everybody to have that conversation and it being part of our everyday discussion that death is a part of life. So let's help everybody prepare for it. And I am really concerned about this younger generation with growing up with all of these technologies. Is they think death is just on TV. They don't understand what it is until they see it in front of them.
Yes, I'll just say a couple of things in response to Rep. Yamane's comments. Stigma is the stigmatized word in mental health. It's the flip side of help seeking, right? That we're trying to promote help seeking life, etc. But that there's so much stigma around everything that we deal with, that we've talked about in this panel. Not just death, mental health issues, depression, help seeking, going to get professional assistance, etc. And I think, again, echoing that role modeling, that we need to role model that as leaders in our professions. Also, I thanks, Val, for your questions in terms of end-of-life issues, I guess, in terms of more discussion, more open discussion about it, to this, just bring more openness to grief, to processing, to debriefing. There's organizations like Hospice. I think some of you know Legacy of Life. They're another local organization that helps families deal with end of life, but also after the individual passes away, they work with the family to see what the family is comfortable with in terms of helping to process their grief, whether it's through journaling, whether it's through a memorial type of service, whether it's through kind of more arts or craft kind of things that they do with to remember the loved one. So there are those services. They're underutilized because, again, the stigma issue and nobody wants to deal with it. But definitely we need more of those conversations in terms of doing better aftercare, post-vention. Again, good post-vention makes for good prevention, and kind of just opens the dialogue that way.
I just want to say one thing real quick. The opportunity to educate, it's like teach what you embody what you teach, is something I try to remind myself. The opportunity to teach someone some skills to help improve their quality of life if they're thinking about ending their life takes first just time and being present for people. And whether it be prospectively, through the efforts that we make in providing care in our roles, or reactively after a disaster, it's just really predicated, improving the quality of life for people and possibly decreasing suicides. Time and being present for people and not really saying much and just meeting people where they're at, kind of like the stages of change, the stages of treatment, and waiting for that opening for them to ask for some form of help. And it may just be asking for a cigarette or a Coke or a coffee. So anyway, just looking for those opportunities.
Thank you so much for that.
Yeah, I just want to actually challenge us to consider the professionalization of what we're doing. And the reason being that is, Kristin, my question to you is, were you debriefed after you came back from Ebola?
We were offered an opportunity. However, it really wasn't a requirement.
Yeah, so in 16 years at CDC, and I saw all the disasters in the United States and many of the disasters in the world, I was never debriefed. And it was never a mandatory thing. And as a matter of fact, if you find the statistics that show the incidence and prevalence of mental health and behavioral health issues among public health responders, I'd like to see that data, because actually I think we're dropping the ball in that regard. I'd like to ask you, what's the incidence and prevalence of mental illness among the Medical Reserve Corps in Hawaii, or the Public Health Department, or the Disaster Medical Assistance Teams, or the DMORTs? And my answer to that is probably we don't know. So here we are giving people advice about public health, and we have no statistics about actually what we're talking about. And so I think part of that problem is the professionalization of what we're doing. We grab a bunch of volunteers and we send them to the field, and we say, come back to us if you have problems. Now let me give you an example of something in public health that we do to protect people from these exposures, and it's actually mandated according to law. If I send you in as your employer into an area where your respiratory system may be affected, not your mental health, but your respiratory system, I'm obligated by law to actually provide you with a respiratory protection program, including fit testing before you go into the place. I also have to make sure and test the environment to make sure that the material that I'm giving you are actually appropriate. And then not only do I not leave you to say, hey, if you get short of breath sometime in the future, why don't you look us up? Or here's a guide on how you can save yourself from that problem of shortness of breath. I actually come back, and it's required by law to have a medical diagnosis of those people on a regular basis, and that's how we discovered the problems in New York after 9/11 among the firemen. And those firemen would not have come forward because many of them actually lost their jobs as a result of respiratory problems. And the same issue with mental health. So I would actually challenge this group and many of the professionals around the country to actually put numbers behind what we're doing. And the reason why I say this and this come to my attention is I most recently had a friend that died in EPA, died of cancer. And I started thinking about it. This was a hazardous material response group, that person that died of lung cancer. Hazardous materials of an entire lifetime, and exposures, and without exactly measuring those kinds of things as well. So when we have these people that are in this profession, we know that we're sending them to austere environments. And I would propose that actually we owe it to them to make sure that they're protected and not leave that to them in self-diagnosis and self-seeking care. We should actually be proactively providing that as a responsibility of occupational health.
Yeah, thank you so much for that. I think that totally underscores kind of what we've been saying about we need to take care of ourselves before we can actually do a good job in taking care of the communities that we're serving. So thank you for that comment. Do we have any questions? I don't know if we're reaching time.
Hi. I was born here at Queens, and I grew up here. I moved to California in college, and I went to grad school on the East Coast. I was in New York for the past decade and just moved back. And so I've talked to a lot of people, been through a lot of things, interacted with many different demographics, and I find that my family is the most difficult to talk to. And I went to Iolani, lots of Japanese Americans, and I wonder if you have any advice for talking to Hawaii Japanese Americans about mental health.
It's both, I think, a challenge, but also an opportunity, maybe. There's different ways that, and I don't have a magic answer for it, but different ways that our partners have handled it. We tend to see that youth are more adept to talk about these issues than adults. They're the ones that are saying, adults, get off your butt because we want to talk about this. Can you stop being silent about it? So since a lot of our, especially our youth-led groups, they're the ones opening the conversation for their parents or for their families. And they're the ones bringing them to have the discussions and bringing them to the trainings. And in my own personal experience, that is what I have done with my family as well. We are a plantation Japanese family that doesn't talk about feelings until their wonderful daughter got into mental health and forced the family to start talking about it. So whether they like it or not, now we don't talk at that, psychologist level depth, but we do check in more than we did when I was younger. So I think just those little steps in starting those conversations, but also, using those broader ways, like using the youth to talk to the parents, can also be effective. Yeah.
Oh, they're looking at me? Okay. The clinician.
Down the table.
When I've encountered that, we do that with that in a wide variety of scenarios, situations. And I guess one of the things that we find is the ability to spend time with the person. The different generations, we find that there's a different concept of time. So the older generation, for them to communicate, they're much more lead by example, the right opportunity. And our younger generation, it's more immediate because the access of information. And so one of the things we would do clinically is when there was an issue, for example, dealing with blended families, or we recommend, dealing with in-laws. Because if any of you dealt with in-laws, right? Right? That's just a whole subculture in itself. But one of the things that we would encourage, or we used to encourage all my clinicians when we had them deal with home or family issues, is for them to spend quality time with that person and allow them the opportunity to share and be oriented to time in their place. Yeah. So for example, when there was an issue that we had, a young client who had a very difficult time dealing with some of her sexual identity issues, but didn't know how to bring it to the attention of her family, we recommended that they first identify the parent that would be the most open to it, and which was her mother. And so what we encouraged them to do was go out and do an activity together where it's not focused on it, they just spent time together. And during that activity, it was supposed to be a dialogue to rebuild, to affirm the trust, the loving and all that. And during that time, she decided to let her mom know. And because it was with her and the mom, they formed this bond, this relationship, on how to address it as a family, right? And so it was a great opportunity for her to grow, and as well as the family. But if she did it, what she initially was thinking of doing, which was like, in front of the rest of the family, there was, it might have been a little bit more difficult. So, like all of us, assess your audience, who you're going to talk to, and time and place and orientation is very important. And for our older Asians, there's a lot of love, and communication is not there, right, okay? However, yeah, however, they're very typically expressive non-verbally, right? They do that, his face, so very easy to work with. So, in the sense of knowing where they're coming from. So, again, part of the discussion, part of dealing with that is starting that dialogue. And many times, the reason why there is no dialogue is because either side, there's just a fear of the outcome. And so basically, we get our clients to address that fear.
So my comment would be that culture you mentioned is not unlike the police subculture, where police officers used to tell each other, hey, it's not okay, you're not a real police officer if you can't help yourself. So the last thing I will tell people is don't listen to your parents. But if your parents are the ones who are telling the family member or whoever that it's not okay to seek help, I would do two things. One is I would tell that person that it is okay to seek help. And then you have to educate your parents or your other family members who are saying it's not okay, because we're all professionals and you are all public health professionals, and we know that encouraging people not to seek help is not healthy. So although we don't want to go against our parents, if that's the culture that they're trying to instill in family members, we know otherwise, and we have a responsibility to help that person.
Real quick, okay, so I got my master's degree in communication, not social work or anything. It's just a novel approach. There's a book that I read called Cinema Therapy. And my mother is Japanese Hawaiian, I'm adopted. And she has a hard time talking about her feelings. And the book that I referred to, Cinema Therapy, highlights how film can be used as a way to engage people who won't talk about sensitive subjects. So I realized that film was a way to engage with my mom a long time ago unconsciously. I went to the movie Joy Luck Club with her. And she, yeah, it was a chick flick, yeah, but she started talking about her feelings, and she was an orphan, and she had issues, abandonment and whatnot, and I didn't know that she had all these feelings. But sometimes just looking at a film that reminds you of things that you might want to talk about might make someone talk about it.
And then you can also use that media to also temperature check with that person, right?
Yeah.
So if the person naturally communicates better with media or writing or video, then just like our youth do, that's a good way to check in and see, are things okay, or are things changing, or are there different themes that are coming out in the writing or the music or poetry or whatever that needs to be checked in with.
Thank you. It's all fantastic answers. Hey, we got one more question, and this is the last question, and I know we can do a whole course on this and discussion, so we're going to give this mic. Here you go.
It's actually just an observation, so it sort of kind of overlaps with what Ryan and Jerry was saying. But it's in my observation and opportunities of working with HPD as well as with Red Cross as HPD is really, really stuck on that, tough guy stigma, and we don't cry, we don't show our feelings because we wear the badge. But I found that when I was able to go in and talk with the commanders, and once the commanders all kind of broke down, and not crying, but broke down and admitted that they themselves were experiencing the problems that I was bringing out onto the forefront, it almost seemed like it gave everybody else permission to be able to follow suit. And so one of the tips or the tricks to the stuff is to maybe get your leaders to lead. We were talking about leading by example, but to get your leaders, they're actually sometimes the key component to opening that door to allow everybody else to be okay, to not be okay. And then yesterday, we kept pressing, just keep pressing and repeating and repeating and re-educating and reposing the question. And sometimes our ears are, the HPD ears are closed to HPD ears, but when you've got someone who's walking the walk and had suffered the loss, that is trying to impress the importance of education, and you take a different route and you have somebody else saying exactly the same thing, you get the same information, but you get a different impact and you make a bigger difference.
That's great. Thank you so much for that. Okay, I think I'm getting the time issue. So, oh, go ahead.
Go ahead. How about a nice round of applause for our panel, ladies and gentlemen?